if you haven't met, I'm Adam. I've been involved in the CFI community for roughly 4 years, and I studied biochemistry at the University of Oxford and doing a PhD in bioengineering. I'll be moderating the talk today with Andrew. Many of you, I'm sure everyone will know Andrew. Andrew Pollard is a professor in pediatric and in pediatric infection and immunity at the University of Oxford, and director of the Oxford Vaccine Group. Most known for the work in the vaccine trial for the Oxford-AstraZeneca COVID-19 vaccine. But you've worked on many vaccines before that, and including meningitis, influenza, and now has advised many different people on how to distribute vaccines, including World Health Organization, and you've been advising the UK government for the past 12 years on how to distribute vaccines in the UK. So thank you so much for being here. And we can give a round of applause. Awesome. The way this is going to work is Andy will tell a little bit of a story about the development of the Oxford vaccine, then we've got a few questions, and then Slido. If you put questions on Slido, I will be checking them. But I had, before we begin, a quick audience Q&A, so we understand the sort of people in the room. How many people here are interested in vaccine research from a development standpoint, in terms of interested in the access to vaccines and how we expand the access to vaccines, or things like people not taking out vaccines because of conspiracy theorists? Is there people in the room interested in that angle? Nice. How many people in the room are interested in more a sort of biological, technical rollout area? So anything from sort of the basic biology of how we make vaccines right the way through to clinical trials and how we run clinical trials. We've got a pretty good spread of biology and policy. Awesome. That's very cool.
I was going to say, who's not interested in vaccines? Thanks very much. Thanks for inviting me to come and say a few words today. So the idea, I think, is to run through some slides. I didn't look at these slides beforehand. From a talk from a couple of years ago, I think.
Yes.
So I haven't looked at them since. This is new for all of us. I can't remember what I did yesterday. It was 2 years ago. Now, so you will remember, as none of us can avoid doing the appearance of this new virus in Wuhan in China. When we really became aware of it in early 2020 in January, that's headline from the 14th of January, and the huge impact that there then was across the whole of the world as a result of particularly older adults affected by the virus as it rapidly transmitted around the world. One thing just to note here on this BBC News headline, which was on the 14th of January, this is the first case reported outside of China. But by then, we already, here in Oxford, 50 miles away, we had the genetic code of the virus. It had already been shared by the Chinese. Authorities all over the world had that code. And the vaccine in Oxford on the 14th of January had already been designed. And that just shows you how the power of science today, being able to get from the discovery at the end of 2019 of a virus affecting people in a small smaller town in China, to a point where the virus had been sequenced and then shared around the world through the internet. One of the things that made this even better from the scientific perspective was that we had 20 years of research already on coronaviruses. So when everyone says, oh, the vaccine was developed really quickly, sadly, no, it's 20 years and then a little bit to the finishing line at the end. Because in 2002, the SARS coronavirus spread, starting in Southeast Asia, and killed about 11% of those who were infected. So the world was a little bit worried about coronaviruses as a result of this one. And then by around 2012, the Middle East respiratory syndrome coronavirus, or another coronavirus, emerged, and that killed 30% of the people infected. And so there was real panic with this virus, which, by the way, is still around in the Middle East today, that it could become more transmissible and create a pandemic. And that had actually driven some funding for research to start on coronavirus vaccines over that period. What I should say about these, the reasons why they didn't turn into a pandemic was simply that these viruses made you sick really quickly. And so you could identify who was ill and isolate them and stop transmission. The problem with COVID-19, which we've all just experienced, is a lot of the transmission happened before people were ill. And so that's the difference. That pre-symptomatic phase made it a very transmissible virus. So we transmitted before we knew we were going to. These ones you could stop easily with just a simple public health measure of isolation. So in Oxford, we started then, after having made the vaccine, started manufacturing so it could go into people. And while we were doing that, ran some animal studies showing that in animals you could get complete protection with the vaccine that we were developing. So by the time we gave the very first dose in humans on the 23rd of April, we already knew that the vaccine gave complete protection in animals. And here you can see these red dots. It just shows a really good immune response in a relatively small number of people to the first dose of the vaccine being given. These were the phase 1 clinical trials. And whenever I look at this slide, it reminds me of the first person being vaccinated on a Thursday, 23rd of April. On the Sunday morning, a fake news website said that that first volunteer had died. And so of course she knew she hadn't died, but her family didn't, and her friends, and all the volunteers who were coming in that day to be vaccinated didn't. And so it was like this huge feeling of panic that we'd already, a few days in, had lost control because of a fake news website. And really, I think we were saved because I phoned the BBC and they did a proof of life interview with her within an hour and managed to squash that fake news story. By then it had spread all over the world, and in West Africa, sadly, it was never quashed, and so there was very low uptake of vaccine because of that belief that the vaccine had killed someone. And the anti-vaccine conspiracy theorists were convinced that the proof of life interview was a fake, because she didn't have a newspaper showing the date, and they could have been filmed before she'd been vaccinated. Anyway, so we also then had to go on in the second phase to look at whether the vaccine worked in older adults. And what these three different kind of lines here show you is that if you were over 70 or under 70, it didn't make any difference. You had really good immune responses to the vaccine by age. Now, of course, in a pandemic, the only people who can get to your vaccine facility are the healthy, very elderly. And what we now know is that the frailest people, those who are in care homes or stuck at home, make much poorer immune responses than the healthy. So if you're healthy over 70, you don't look very different from a younger person. But the unhealthy make slightly poorer responses. And to then move to the next stage and to test the vaccine on a large number, and actually find out whether it worked, not just whether it made immune responses, but whether it protected people. We then had to run clinical trials in about 25,000 people, and doing that during lockdowns, but all across the UK and in Brazil and in South Africa. And the reason for running the trial in multiple places, first of all, we didn't know whether the next wave of COVID would come, so we had to be able to test it and see whether it stops the cases. You have to be where the next wave is. But then also importantly, you want to test in different communities with different types of society, different wealth, different ethnicities, that then builds confidence that the vaccine works wherever you are based in the world and whatever your background is. So that's those clinical trials. And then we also partnered with AstraZeneca, which I think was the most brilliant partnership possible, because they agreed to develop not-for-profit. And the thing that really changes the game here is as soon as you go not-for-profit, the pharmaceutical company has no incentive only to sell to the richest, which meant that they would make their vaccine available just as much to a low-income country as a high-income, because it made no difference to their bottom line. And most other developers took the view that it was for profit, which meant most of the doses went to high-income countries first. So AstraZeneca ran some trials in the US, and tried to run trials in Russia and also in Japan. And lastly, there was a partnership with Serum Institute of India, the largest producer of vaccines in the world, and that was astonishing because they made such an enormous number of doses. In total, with the 24 different manufacturing sites we had, we made 3 billion doses of vaccine, and about half of that came from administered in India. So as we get to these phase 3 trials in the different areas, the thing for me that is absolutely astonishing at that moment is not only were there 2,000 researchers around the world all working for development and working really hard to do that, but there's 25,000 people, members of the public, who have stepped forward, all sorts of different backgrounds, but said we really want to be doing something in the pandemic to help humanity. And the consent form, we have to tell them we don't know if this vaccine is safe, we don't know if it will work, and they still have put their arms out and wanted to take part, because it really matters when they're seeing friends and relatives and parents who are suffering from an illness with COVID. So that then led to the first results at the end of November, which were then used for the licensure of the vaccine at the end of December in the UK by our regulator, the MHRA, which you can see there. And that licensure then meant that the rollout could start on the 4th of January. Now you can see me, the third person to get a dose of the vaccine in Oxford. Can't see whether I'm smiling or not, but I got the third dose. And then the European Medicines Agency approved the vaccine, which allowed the World Health Organization to start the process of the global rollout. And perhaps the most important moment was the 24th of February in 2021, when COVAX started shipping our vaccine all over the world. And the reason why that's significant is they couldn't get any other vaccines. So going back to my point about selling to high-income countries with the other developers, the only vaccine they could get hold of was the one from Oxford, because this was largely given distribution to their middle-income countries, where there's very little financial incentive. And about 90% of the doses went there. So this was a headline in August of 2021. And so by that stage, the estimates in the UK were already about 100,000 lives have been saved in the UK. And half of the doses were Pfizer and the other half was from the AstraZeneca vaccine. And we now have some data looking back at the whole of 2021 globally at the impact of immunisation. And somewhere between 14 and 20 million lives were saved in 2021, so just looking at that segment. And this company, Affinity, has tried to separate out by which vaccine was used in which country and the impact of different vaccines. And obviously I'm showing this, I'm so pleased that on the left is our vaccine, which wins this. I probably wouldn't have shown that. But I think the important thing here is the reason why AstraZeneca wins is because it was distributed globally and focused on those who are most likely to die, which is the elderly. And Pfizer has a large number because they sold almost exclusively in 2021 to high-income countries where there's a lot of old people. And so they also had a big impact. But it's important to also note that all of these other vaccines that were used saved lives. And if we hadn't had all of them, and then there would be a lot more people that have died during that year. Once you get to 2022, most people had already died because the virus had spread so widely, so those who were going to die had already died. And so doses that were then made available in 2022 had much less impact. And most of the impact was what you could do early. And that's why the rollout of the Oxford vaccine and some of the Chinese vaccines early 2021 had the biggest impact. So I'm going to stop there. Lots of people involved obviously in these studies and reasonably, I'm going to say generous funding, not very generous funding from the UK government. We got about 30 million for the development in the UK. Every developer in the US got $1 billion from the US government. So it's done much more cheaply than it was in Europe. I'll stop there.
Thank you so much, Andrew. I forgot to read out the Slido number, which is, oh no, you guys already have it. If you don't have access to the link on the link of Slido, the number at sli.go is 11